a great diagram because the white arrow shows us the initial longitudinal tear that occurs completely through the white layer, which is our intima. This is our intima, this is our media, this is our adventitial layer, this is our internal elastic lamina, this is our external elastic lamina. The problem with this tear is that we create a false lumen because there will be blood traveling in this way, collecting in this plane of the media. It is not a true lumen because, number one, it's obviously a tear through the intima into the media, and it doesn't go anywhere. It just accumulates blood within this area of the vessel wall. You need to watch out for this in hypertensive patients, particularly poorly controlled ones, because hypertension eventually damages the vasa vasorum that supplies the tunica media. So again, the diminished flow through the vasa vasorum will cause hypoxia within the media, and weakening of the wall will ensue. Individuals with a bicuspid aortic valve are also predisposed because they usually have a fibrotic bicuspid aortic valve that requires higher pressure to open. These patients essentially will always develop hypertension due to only having 2 cusps instead of 3. So again, here's a 2 cusp versus a 3 cusp aortic valve. There's just more wear and tear on this second element than having 3 cusps to it. Now, what are some other things we need to worry about for people that might be disposed to having aortic dissections? Of course, we need to worry about someone with a connective tissue disorder because the layers of the aorta are composed of that kind of tissue. It doesn't just have to be Marfan syndrome. What are some other ones that we can have? What about Ehlers-Danlos? Or someone with a vitamin C deficiency. Remember, you need vitamin C to hydroxylate some of those proline residues, and that way you can have cross-linking of very important connective tissue elements, particularly collagen. So why is this aortic dissection a problem besides, obviously, death? Can the tear heal? No. It is like an ACL tear. You need surgery. You have to fix these. Here's a nice little image of the different types of aortic dissections that can occur. The intraluminal tear cannot heal on its own. The chronic high pressure within the aorta will just continue to pound through the media and form an intraluminal hematoma. The dissection can extend any way you can imagine, really. So, in the example of B, you can see that this little hole here with the blood arrow going through it signifies that that's how we're forming a hematoma within the vessel wall. This is a really big concern with these tears because the adventitia of the aorta is continuous with what structure? The epicardium. So, why is that concerning? Well, besides that we can rupture the aorta at any point where there is a false lumen due to weakness, it's trying to hold on for dear life against that high systolic pressure. The fact is that the dissection can even travel retrograde. So our tear can increase, and we can start accumulating blood going down this way or back this way. If it travels retrograde, it can cause blood to quickly accumulate in the pericardial sac, and now we not only have an aortic dissection, but we have cardiac tamponade. Another potential situation is that C, we have a distal dissection. This is past the left subclavian, and it is in the element of the thoracic aorta, and it will continue to grow down towards the abdominal aortic element. And that is a tear in the descending part of the aortic arch, and it just extends toward the renal arteries. So in the last example of A, this is a really bad situation. You can see that the entire aorta is involved as the dissection progresses everywhere. So how would you even know that if a patient had this going on? Well, the pain is referred to the back. They have tearing chest pain. If you see tearing in your vignette, you're talking about an aortic dissection. No matter what, it is guaranteed tearing chest pain. It is not like GERD. That is a more acidic, burning, under the sternum pain that can be confused with angina. In the presentation of a patient with aortic dissection, they will say it is excruciating, tearing pain that is radiating into their back. And that makes sense because the aorta is retroperitoneal. The nerves of the retroperitoneum will tell you that the pain is referred somewhere in the back. And it is a tearing pain because there's literally tearing going on. Right? Great. Let's continue with ischemic heart disease. Now, what do we know about angina, besides that this dude is suffering from it? We know that angina is Greek for strangling. And that's rather interesting because that is kind of what is happening to our myocardium when we are depriving it of sufficient oxygen supply by either undesired vasospasm or stenosis that narrows the lumen within each coronary artery. Now, what actually happens when the demand exceeds the supply? So when there is insufficient amount of oxygen, The myocytes are smart and know that they have to keep working somehow, despite the decrease in available oxygen. So there's decreased available oxygen. We eventually decrease our available ATP. They switch over to anaerobic metabolism, right? You can make 2 ATP that way. And unfortunately, this leads to a lot of lactic acid accumulation. In addition to that, the precursors of ATP accumulate. So we get lots of adenosine, lots of ADP, and lots of AMP, right? This is beneficial at first because we know that adenosine actually can vasodilate our coronary arteries, right? But the ability of adenosine to vasodilate the coronary artery is burned out within 30 minutes. So 30 minutes, we are toast on our adenosine, no more. That means that there can be continued myocyte ischemia and it can lead to necrosis if we don't do something. At this point, though, we're only at the level of low ATP and the cell will be swelling. Why will the cell be swelling? Well, here's our myocyte and here's our sodium-potassium ATPase pump. Remember, we pump sodium out and 2 potassium in. If this cell is deprived of ATP, sodium will accumulate within the myocyte, and guess what comes in? Water. So this is a great way for test examiners to test your fundamental knowledge of pathology. The first step in any type of ischemia, you would have balloon-like dilation of cells due to accumulation of sodium that pulls in water. So again, what happens when we accumulate sodium within a myocyte? Water will follow into the cell and cause the cell to swell like a balloon. This swelling disrupts the integrity of the membrane, and even though we accumulated some sodium within the cell, there is still an incredibly high concentration gradient for ions to flow across these leaky membranes into the myocyte. This is the fundamental principle why you see ST depression in angina. Now, why do you see ST depression in angina as opposed to a myocardial infarction where you see ST elevation? So remember, we have our endocardium, our myocardium, and our epicardium. So remember that the last layer perfused by the coronary artery branch is this subendocardium, right? The layer that's sitting, so this is our endocardial layer. So this is our coronary artery running in the epicardium. It is lastly going to provide this subendocardial element here, because this endocardium and this myocardial layer and this epicardial layer are all represented in our diagram. So the subendocardium is the last to get its blood supply from the blood in the coronary artery vessels. Remember, the endocardium itself is fine. It gets blood from within the chamber of the left ventricle, or whatever ventricle we're talking about. So I'm basically telling you that the layer farthest away from the coronary artery will be affected first. So the myocytes in the subendocardium here are not able to use their sodium-potassium ATPase because there's not enough ATP. This means that we do not restore the normal sodium concentration outside of the cell, and therefore we do not restore the positive charge on the outside of each cell. So if you can imagine this is our myocyte, normally we have very electronegative inside and very positive outside. But the fact that we can't pump our sodium back out, we have a disruption of this normal gradient. Remember, we're supposed to pump out 3 sodium anions and pump in 2 potassium ions. So there should be a net positive 1 restoration on the outside of the cell membrane. This means that the cells will have a net negative charge on their outside because this is abnormal. They are not able to get rid of the highly positive sodium intracellular environment, and they start accumulating negative on their outside because there's 1 more sodium on the inside as opposed to 2 potassium stuck on the outside. So there's now a difference in charges. The subendocardium has a net negative charge. So if you think about it this way, there's 3 layers to the heart, and this area will now be more negative as opposed to these areas that are able to fully restore themselves because they are last affected by low levels of ATP because they're not the last level perfused by the coronary artery branches. So what have we created here? We've created a vector of depolarization. Remember, negative to positive. That's how vectors of depolarization work. And this electrode will sense an upward deflection, right? But the problem is that the baseline here created in our ECG is a relative baseline. It's saying that, well, what is this electrode versus this electrode versus this electrode? Is there a relative change in the electrical potential between all of them? And the fact is that yes, there is, because these cells are ischemic and they did not restore their normal cell potential. They're negative, while these cells of the myocardium and epicardium had no problem restoring their positive potential. Now there's a depolarization that is going on at this point in time. So there's a shift of the baseline up because the electrodes read some sort of depolarization activity. And remember, whenever you have depolarization towards an electrode, it is an upward deflection. So how does your ECG reading read voltages, right? No absolute values. So again, baseline is shifted up because the electrode reads that there is a voltage difference due to the subendocardial cells not restoring the positive charge on the outside of their cells because they are unable to pump sodium out efficiently. Basically what I'm saying to you is that there is a charge difference in which current can flow from the ischemic cells in the subendocardium to the normal ones in the myocardium. This vector is pointing towards the electrode, so the baseline will be shifted up because it reads it and inscribes positive deflection. And that means that when we have our normal depolarization of here and then it resets, it looks like it's lower, like it's ST depression, right? But in fact, it's not this ST segment that's going lower, it's actually this baseline shifting up. So it gives the appearance that the ST segment is lower. So a non-ST segment elevation, MI, or angina, has this presentation for that reason. Now, what about the pain element that you see in all types of angina? Anginal pain is rather simple. Just think about it when you're working out really hard, and let's say you're doing bicep curls because it's arm day, and you've pushed your muscle to its limit. You sense a deep burn and aching sensation. That is the exact same that happens in angina. Your myocardium is just another muscle, except that it's a special type of muscle, and when you push this muscle to its limit and deprive it of oxygen, it is going to tell you by sending pain signals via C7 and T4 visceral afferent fibers back to your brain, and you're going to sense pain.